Just Some Podcast Media.
The thoughts and opinions on Just Some Podcast are of the hosts and guests and do not represent the views of organizations that employ them or they volunteer for. They are also not responsible for spontaneous black holes or nuclear wars that may occur. You have been warned.
Welcome, everybody, to another fun-filled and exciting episode of Just Some Podcast. This is Tom.
Hey, this is Ben. Tom, how you doing, man?
I have been doing great, and I apologize to everybody now if there is a minor gap when I talk sometimes, because I do have the NFL draft on in the background, so not that it precedes this episode in any way, but I will probably turn my head every once in a while to see who picked up who.
Yeah. I was watching that right up to the point that I hit record. We were watching the draft, see who got their dreams made of going the big leagues. So it was pretty awesome.
And I am nothing but super happy for all the people that make it. You know, they worked hard. It's a huge accomplishment. Big shout out to all of them. I just really hope Cleveland picks the right people. I'm just saying.
Are you going to be a Bears fan now?
Well, I'm not going to be a Bears fan. I didn't dislike the Bears, so this kind of helps me like them more. But yeah, I mean, I really like pro football, but college football is my mainstay.
I know.
So when it comes to pro football, while I'm a Browns fan, I feel comfortable rooting for the Niners or the Cowboys or the Chiefs or the Bears, whoever's not Tom Brady. That's who I'm rooting for. I'm joking. So
here's the real question, Tom. They're holding the draft in Cleveland. Why aren't you there?
And this part might catch a boo. I literally didn't know it was in Cleveland till tonight. Yeah. So when I started watching the draft, it says from Cleveland. I'm like, Cleveland? You're purposely holding it in Cleveland? Like, did someone lose a bet or I couldn't figure out what happened. So,
well, last year it was all remote because of COVID-19. So I feel like they probably just had to reset, and they're like, well, where's the worst place that we can go after being at Cleveland?
Well, I was going to say Pittsburgh if you were picking the worst, but
I mean, yeah. Detroit just barely fell out of the...
Detroit, the only place that people in Cleveland look down on. So there you go. Yeah. As a matter of fact, if you YouTube it, there is a Cleveland tourism video. There's two of them, and they're both hilarious. But that's actually the catchphrase in one of them is, at least we're not Detroit. I highly recommend people look that up, as a matter of fact, now. So, but no, otherwise, things are great. Work is super busy. Good problem.
Yes, not a bad problem to have, definitely.
Yeah, the hardest problem is keeping up with the charting. It's like trying to drink from a fire hose right now, but... No, realistically, other than that, everything's great here. How are things in your neck of the woods?
Very similar, very, very busy, difficult to keep up on the charting. It's kind of like I've said before, and I tell all my students this as well. Charting and family practice is kind of like running on a treadmill. You're never really going to get caught up. You're just hoping not to fall off the end. I mean, and that's pretty much where it is. Like, as long as you're somewhere in the middle, you're surviving.
Yeah, I want to be caught up, but... I'm probably not going to be, at least not in the next 24 hours. So,
and then they just turn it up faster if you do catch up. So
yeah. Who rigged this game? That's what I want to know. But no, I'm super excited. We're doing another Back to Basics episode. We're going to be doing some education on hyperlipidemia, which not everybody thinks of as, exactly. Not everybody thinks of as a super exciting topic, but it is extremely important. It's something that I would say almost all, if not all, family practice is going to either deal with directly or indirectly and have to treat. So while not sexy in the sense of something flashy or fun, it is definitely educational. It can be very cool to learn about, and it is important.
Yes, it's not going to be Dyatlov Pass, but it is definitely something that's vitally important. And like you said, we all test for it, we all treat it. So, it's good to have that back to basics kind of overview understanding. Those that have been out for a while, it's a nice review. For those who are just getting out or in school, hopefully they'll get something from this episode.
Speaking of the Dyatlov Pass or the Medical Mysteries episode, we have got a, dare I say, tsunami-like wave of good information, feedback, reviews, and people wanting us to do more. So I'm kind of excited at how well the episode went. I am very interested to do some more. If you are listening to this and you know of a cool medical mystery that you think would be fun to be reviewed, please just let us know and we will take a look at it and maybe go from there.
Yeah, I can tell you, that we have selected our next medical mystery episode topic. Going to be another interesting one that is still unexplained, and so hopefully that'll be coming out here in the next few weeks.
Aliens. I'm just going to call it now. I'm not saying aliens did it, but aliens did it.
Lupus.
It's never lupus. Yes, House. It's never lupus, except for those times that it is. I'm like, the ANA says different.
Well, if you want to get hold of us and tell us about a medical mystery that you think we need to cover and put our spin on, you can find us on Facebook, Instagram, Twitter, and YouTube, all at Just Some Podcast, website, www.justsomepodcast.com, our email, admin@justsomepodcast.com. Hey, don't forget to check out our other shows that we have under our nice little umbrella. You got Buried Pleasures with Polly and Amazing. You got Nurse Papa with David. Again, great shows. Give them a listen wherever you're downloading your podcast right now. Tom, I don't know, let's say, beyond giving us topics, what if they wanted to help us out somehow? What could they do?
Well, the best thing that they could do is they could go to our website. They can go scroll down to just about the bottom of the page, and there is an Amazon affiliate link. Click on that before they do any of their shopping, and then go to the website, put things in their cart, go about their day like we weren't even there, and it would really help the show, and we'd appreciate it. Like, for instance, bamboo hand back scratchers. That is a fantastic thing everybody loves and is super useful, and I am using one right now.
Or maybe you need a wood beard comb, and you want to comb that magnificent beard of yours, and you're like, where can I get one of those? Amazon. But make sure you go to our website first and click on our link.
Absolutely. I mean, it's stylish. It's got great utility. I mean, you could probably use it for other things. Like, if something scared you, you could throw that comb at them, hit them right in the face.
That is true. I mean, and you can play a little bit of music with it. I mean, it's multifunctional.
Multifunctional. That's the important part.
We need to get our stamp on this or something, man. I'm telling you. Well, Tom, are you ready for a story that you may have missed?
Well, if I said no, would that make any difference?
Nope. We would still be going there.
Okay. Well, then, yes, I am absolutely ready for this.
Okay. Well, Tom, if I told you the phrase M as in Mary, K as in King, so MK4482, what are your thoughts?
CIA cover-up.
Aliens.
No, when you said MK, my first thought was MK Ultra, which is a conspiracy. I mean, it was a real program, but it's a conspiracy. It's linked to every conspiracy now. So I can't think of anything else now. So what does that mean?
Well, MK4482 is currently an oral antiviral that is being tested in clinical trials and is a drug that has been listed to successfully treat SARS-CoV-2 infections in hamsters.
Is this by Pfizer?
I don't know. It just talks about the scientists that are testing it in human clinical trials.
I happened to see today a story about Pfizer is trying to make a pill to help with COVID-19 and symptoms. So that's why I was like, oh, is this?
Breaking news. This is apparently Merck and Ridgeback Biotherapeutics are the ones who are currently conducting phase 2 and phase 3 human clinical trials of MK4482. Like I was saying, it does show the effectiveness in hamsters currently. If the trials can confirm the therapeutic value of MK4482 in humans, it'll be the first drug for SARS-CoV-2 that people can take orally within the community. It does show promise for stopping MERS and SARS in epithelial cells in vitro and in mouse models. And in some cases, it talks about how it says in the current studies, researchers tested the effects of MK4482 using 3 hamster groups, allocating 6 hamsters to each group. The researchers gave the drug to the first group of hamsters at 12 hours and 2 hours before infecting them with SARS. The second group received the antiviral 12 hours after infection. And when the trial concluded, researchers found that the animals who had received the drug had 100 times lower levels of infectious SARS-CoV-2 in their lungs than the untreated group. So again, this is currently going into the clinical trials. It's going to be a very short story that you may have missed because there's not a lot on it because it's still in trials, but it is showing some potential promise for maybe a light, even a brighter light than the COVID vaccine as far as the light at the end of the tunnel for COVID. So Tom, what are your thoughts?
First of all, I'm super happy that we are continuing the good fight against COVID-19, including medications to help. However, I would still tell everyone out there listening that by far the best treatment for COVID-19 is prevention.
True.
So washing your hands, wearing your mask, getting your vaccine, those are all things I highly, highly recommend. There is no 5G antenna in it. If there was, my cell phone would not be dropping calls. So the point is you're going to hear a lot of bad stuff, but the vaccines aren't out to get you. It's important that we prevent as much spread or people getting COVID-19 as well as trying to treat it afterwards. So that's my take on it.
And I will say, you said that the best treatment is prevention. You will notice that Tom did not mention ivermectin, Plaquenil, or azithromycin as potential best current treatments.
Yes, prevention, not the other stuff. Though I do think with resulting pneumonias, there was some studies done on the azithromycin, and the ivermectin, I think, is still being trialed in some other countries to help with
there are trials
options.
ongoing. Yes, yeah.
Plaquenil, that one, nope, no good. But like you said, I'm still happy they're trying to get even more treatment. So good job.
Well, let's what we'll do is we'll take a little break here. On the other side of the break, because we're going to jump into our back to basics on hyperlipidemia. But let's say, I don't know, you wanted to invest in some crazy company like Merck who's currently doing clinical trials, or maybe you just want to see where your financial portfolio is. Give Scott a call.
Are you lacking financial direction or need a second opinion? If so, My NP Advisor is a virtual financial planning practice that focuses on working with nurse practitioners, and they've developed a unique process that evaluates 5 key areas of your financial life.
They call it the Check My Vitals procedure, and for $500 it addresses some of your biggest financial concerns, like, am I saving enough to maintain my lifestyle in retirement? Is my family protected from a catastrophe? Do my investments match my tolerance for risk?
Listen, if you have more questions than answers, then you're probably due for a checkup. So, click on the link in the show notes to learn more about the 5 benefits of checking your vitals. And if you're ready to move forward, you can even schedule your appointment directly from that link.
Yeah, the link is down in the show notes.
It's a great place to start.
Securities and advisory services offered through Royal Alliance Associates Incorporated, member FINRC SPIC. Additional advisory services offered through Premier Financial Partners LLC. Neither Royal Alliance, My NP Advisor, Primary Financial Partners, Just Some Podcast, or any other guest or affiliate.
So Tom, back to basics. Hyperlipidemia, that damn difficult disease to treat. And I don't mean difficult as in like we don't have medications for it, because as we'll get into in a little bit,
we got plenty.
There's an official pant load, I believe, is the official measurement of medications. But the problem that I have personally, before we start getting into this, and I want your take on this as well, patients don't feel anything.
Yeah.
And so it's very, very hard to treat, because if they have diabetes or they have hypertension or they have anything else, not anything else, but some of your bigger ones that we treat frequently, if your sugar is 500 and we give you insulin and you bring it down to 150, you feel something. If your triglycerides are 3,000 and we bring them down to 1,200, you don't feel any different per se.
So that is definitely one of the hardest aspects of hyperlipidemia is dealing with what you just said. It's not tangible. They don't feel it. They don't see the onset. And even once we treat it and things are better, they're like, yay. Like I took a capsule and something happened, and now you took blood and now you're telling me it's better, but they don't notice any better. So that is difficult. And as we were just mentioned in the previous story we may have missed, this is also a case where prevention is a much better option than the treatment. Not that treatment isn't important, and not that every type of hyperlipidemia can be avoided, but the majority of them can be. So this is also one of those times where part of the treatment, I know when I go over it with my patients, is not talking just about medications. It's talking about dietary and lifestyle changes that can also affect treatment.
Your enthusiastic yay there when you're talking about, when we treat it, kind of reminded me how Browns fans are whenever they announce draft picks for the Browns. There's kind of like, yay, someone else to play for the Browns.
Yeah, well, when you realize you're a Browns fan, there's not really any more cheering left. So you realize the inevitable torture that you're just going to put yourself through in every football season.
Well, Tom, let's kind of break down, because hyperlipidemia is a nice umbrella, kind of a basket term for it. But I mean, there's multiple levels to this. And so let's kind of start getting into some of that. What do you say?
I think that's a really good starting point.
Let's first look at the one that I think we see most frequently as far as being like elevated, and that would be your triglycerides. Would you concur?
I absolutely concur. And it also affects several different things. Like you talked about diabetes earlier. This is one of those factors that if you are dealing with patients that you're afraid of developing diabetes or have diabetes, this is one of those markers you need to keep your eye on. Well, all of them you do, but this one in particular.
And I do tell patients that the triglycerides tend to follow sugars. So if their sugars are going to be out of control, their triglycerides are as well. Just for definition purposes, hypertriglyceridemia is going to be anything greater than 150 as part of the lipid profile, which includes the HDL, LDL, total cholesterol, and then the triglycerides. Yes.
Oh, the thing we were just talking about.
Yeah, thanks. Normal, like I said, is less than 150. Moderate is going to be 150 to 885. And anything greater than 885 on your triglycerides is considered to be severe hypertriglyceridemia.
That is quite a bit. Realistically, I always thought in my head the marker I set was 500. You hit the 500 mark, you're up there. And I know that may not be the official, but as with just about everything else we're going to talk about in this episode, a lot of it is going to be subjective. It's going to be how the clinician is viewing it and dealing with that patient and that patient's situation.
Yes, I think you can think of cholesterol as the correlate clinically disease. What do you think?
I think that's the best way to put it.
And so some of with the triglycerides or even with the cholesterols in general, what I tell patients is it's going to be about 50% genetics, 50% dietary. So I have patients, as a matter of fact, I have at least a few patients that I know of that have cut out as much of their diet unhealthy wise that they can. They're doing what they're supposed to be doing. They're exercising. I mean, everything, and their cholesterol and their triglycerides are still a little bit elevated. And I'm like, it's bad DNA. I mean, it is what it is.
There is a genetic component, okay? However, for the majority of our patients, commonly associated with hyperlipidemia is going to be high-fat diets, sedentary lifestyle, obesity, and diabetes, okay? Again, it's one of those, I can't make you feel the cholesterol in your blood, but I'm pretty sure, like I said, for the vast majority of our patients, I can point to something and say, this represents the condition that you are having.
Yeah, and I will tell you, you said you can't see the cholesterol or triglycerides or, which is very, very true. In my office now, because we're a satellite clinic, we draw our own lab samples. And I guarantee you in blood, you can see high cholesterol. Like when you spin it out and there is, the red cells, the plasma, and then this nice kind of Well, it looks like bacon grease. I mean, for
There it
lack of a
is.
better term, it's like, oh, that cholesterol is not going to be good at all.
Well, and for lack of a better term, that's what it is. It is bacon grease. It's our fat. It's just not, the fat from bacon. But that is, in fact, what we're dealing with when we're dealing with these conditions. So here is something that we talked about: clinical correlation. When do you break it down for your patients as this is where you're at, this is where you need to be, and when do you start treatment?
And again, that will correlate clinically. If they're diabetic, I'm not going to be overly aggressive with the triglycerides if their diabetes is out of control as well, just because I know that if I can get their sugars under better control, that triglycerides are going to come down as well. But yeah, I mean, if you're starting to get 250s or higher, for me personally, we're going to start having some conversations. And I think we'll kind of get into the conversations we have in general here in just a little bit. Where are you at as far as like for your triglycerides?
So when it comes to, I take a slightly different approach is when I do have a patient that's like, for say, diabetic and their triglycerides are out of control, I tend to clamp down harder because I'm like, hey, this is a direct reflection. You need to be avoiding sugars and carbohydrates. I can tell you right now, I'm looking at it. They're elevated. If we can get the triglycerides under control, that's going to help with sugar control. Personally, when I'm talking to a patient, again, every situation being different, assuming they're non-diabetic, 150 is obviously the range. To 250, I generally am talk to my patient, talk about diet and lifestyle modifications, and I'm not big to push medications. After 250, I start going, hey, you either need to get serious or we need to talk about medications. But honestly, over 350 is when I start going, and again, I always tell my patients, it's your body. I'm not going to make you do anything with it unless you're a threat to yourself or others. But that's when the conversations tend to get less, hey, try not to have a donut tomorrow, to, hey, do you like arteries? Because if you like to keep
Arby's?
them.
Yes, I love that.
Yeah, exactly. But that's generally the levels. And again, it's also dependent on the patient and how receptive they are. Because some people, they didn't realize. They're like, oh my God, I didn't know. You tell them, you retest in a couple months, and guess what? They're doing much better, or you can at least see the improvement. They're going, hey, I started checking my blood pressure every day. I started going to the gym. I tend to give them a lot more slack. It's the people that are not making any effort, or with effort, they're not making much headway, that I tend to go, okay, I think we need to address this medically.
And I do try to provide the education to patients as far as the dietary modifications, like your dietary and activity modifications. And most of them, I'll kind of give them the opportunity to self-correct by making better choices, because a lot of them don't want to be on medication. And I get that. But, and I guess we didn't really put this in the beginning, and maybe we should have. Why do we treat cholesterol, Tom?
Because they told me to.
Well, yes, but beyond that, we're trying to prevent things
like heart attacks. Yeah, like heart attacks, diabetes,
strokes.
Yeah, the whole, do you like your veins and arteries because you're clogging them? Trying to avoid stuff like that.
And that is one of the things that whenever I'm talking to patients about their cholesterol, that's what I'm like. Because patients freak out about heart attacks, and I'm not saying they shouldn't because they're bad. But
is that going to be an episode?
It should be. Heart attacks are bad. The end. Play the music. That's where their mind goes when they think cholesterol is heart attacks, but it is more than that. And I think when you start opening up that knowledge base to say, no, while the heart attacks are what we're concerned about too, there's other things such as, do you like the left side of your body, and do you want to continue to use it appropriately? And when you start talking about strokes, and they're like, oh, because people know what a stroke is, and they realize that it may not kill them, but it is going to potentially be very debilitating, whereas a heart attack isn't always as debilitating as, say, a stroke.
Yeah, it always seems like they had one person like, well, my granddad had a heart attack, and he lived another 30 years. So I'm like, oh, not that I'm not happy for granddad. It seems to set back the realistic expectations the patient should be having. Is because your grandfather did well does not mean that you will. And having that conversation about triglycerides and cholesterol with a patient, sometimes you need that reinforcement. And just like you said, heart attacks aren't always as debilitating as something like a stroke. That is something also, though, I point out, like you said, with strokes, I go, if you have one, imagine having someone have to spoon feed you or dress you the rest of your life. And that's something that most people can imagine. They put their own pants on. Having to imagine someone else doing it for them kind of sells that or brings that home for them a little bit.
As far as treatment options for triglycerides, your big go-to is you're going to be your fibrates.
Yeah.
2 available in the United States currently, and I use both of them. I probably use the gemfibrozole more than I use the fenofibrate, but
really,
yeah, and I think it's just a mental thing. I don't know. That's the one I just think of first, I guess.
Okay.
However, evidence shows that the fenofibrate is considered to be a safer drug than the gemfibrozole with fewer interactions, and it's also easier for compliance due to it just being a once daily versus the gemfibrozole, which is 600 milligrams twice a day. The fenofibrate is 145 milligrams daily.
And I wish I could say all the cool stuff like, no, I read all the safety inspection stuff, and that's why I picked it. But to be completely fair, a big factor for me is patient compliance. It doesn't do me any good to prescribe them medications they don't take.
Right.
So the chance of them taking fenofibrate once a day is a much greater than with the other. But yeah, I'm a big person on the fenofibrate starting off with if needed. And we are going to talk about statins more in depth, obviously, with the cholesterol portion of this. But there are, with the higher dosages of the statins, you will get a lowering of the triglycerides as well. So you can't rule them out. It's just that's not my go-to for my first line treatment if it's purely just triglycerides that I'm attacking.
And because patients will ask you, there are some potential natural things that they can do to try to help other than dietary modifications. One of those is fish oil, which can help potentially reduce triglycerides. However, it can potentially interact with some of your blood thinners, so be mindful of that. But it's basically the omega-3 fatty acid in the fish oil is what can help lower triglycerides. So that is one option that they can get over the counter.
That's a good option. Niacin is something that is also not a traditional, it's not a fibrate, it's not a statin. However, not all niacin is the same. So prescription niacin is not going to be directly the same as over-the-counter niacin. And there have been, and I'm getting this from both the American Heart Association and the American Academy of Family Physicians websites, that there have been issues with people taking large doses of over-the-counter niacin because it's not the same, and having not just bad reactions, but also having to be seen by medical staff. There's good and there's bad with everything. Just be wary if your patients talk about niacin that you educate them about the correct dosages and routes to be taking that, as well as the fact that niacin, while works well, traditionally has some side effects when it gets into the larger doses, such as skin flushing and lots of itching. And so maybe the patient doesn't want to take a fibrate, they don't want to take a statin, but they're probably not going to tolerate niacin very well. So that's just part of making sure that conversation, like, well, you can try it, but I have a feeling you're going to be taking some fenofibrate here shortly.
Anything else that we kind of didn't hit on as far as like the triglycerides before we examine the rest?
And I know you kind of talked about it earlier, but the big thing, especially when you're educating your patients, I am a big person on reminding them that triglycerides are your carbohydrates and your sugars. So really watch that, and you can really reduce your triglyceride levels through diet if you're just willing to cut out those carbohydrates. So just seems to work well for most of my patients.
So you want to move on to the rest of it. So let's move on from triglycerides to...
Was that too sarcastic?
Tom, what are some of the differences between... So you have your total cholesterol, you have your HDL and your LDL.
Correct.
Can you give a quick review of what kind of breakdown of those are, or what the difference between them are, I guess?
Well, I mean, some of it is in the name itself. So cholesterol or total cholesterol, obviously, that's going to make a lot of sense here in a second. The two main things to factor when you're treating cholesterol or when you're looking at your lipid panel is you're going to be seeing your LDL and your HDL. Okay, so the LDL is the one that we are trying to avoid. The LDL is the cholesterol that is going to cause the major issues such as the MIs, the strokes. It's the one that everyone worries about. When they think of cholesterol, this is the bad one.
Yeah.
There's plenty of journal literature and studies that show a direct correlation between high LDL scores and factors and those conditions we were just talking about. On the flip side is the big brother of LDL, HDL. HDL is a good cholesterol, and we actually want that not so much high, but we want to make sure that it is in its normal range. There is a proportion as LDL goes up, HDL tends to go down, which is not helpful to us in any way because, like I said before, we want that HDL up. So in treating LDL, we can actually help the HDL go up, which is something that's very helpful to us. Did that make sense, or did I miss the mark?
No, I think it made sense.
Well, thank you. Because I was like, I hope he's not like, what's the chemical structure of LDL? I'm gonna be like, fuck, I don't know. it's
Why
the
not?
one. Oh, you
It's
think
the
I'd
bad
have the
one.
internet in front of me?
And
So-
the way that I, and I'm sure that everybody probably knows this, but just, the way I break it down to patients as far as that goes is the LDL is the one that we want low, hence the L. The HDL is the one that we want higher, which is the H. So it's an easy way for them to remember which way that we want those numbers to be. And looking at kind of the rationale for lowering LDL, I found this kind of interesting. There's a 2016 meta-analysis evaluated outcomes in over 300,000 individuals at a broad range of risk in 49 trials. Mean baseline LDL was 122 milligrams per deciliter. And the following was found that relative risk for the endpoint of major vascular events per 38.7 milligram per deciliter reduction in LDL was 0.77 for statins and 0.75 for non-statins. And among primary prevention trials, the post-treatment LDL was positively correlated with CVD events, meaning that the lower post-treatment LDLs were correlated with lower event rates, and higher post-treatment LDL levels were correlated with higher event rates. So basically, they're saying that lowering the LDL with statin therapy for primary prevention is effective at reducing those cardiovascular events, such as cardiovascular death, acute coronary syndrome, coronary revascularization, or the strokes, and then also myocardial infarctions over a wide range of baseline LDLs and lipid profiles. Produces a similar relative risk reduction to statin therapy and secondary prevention, but a lower absolute reduction. So that's kind of the rationale behind why we want to treat that, because all that big, long medical jargon to say that treating it helps to decrease the cardio events that we were talking about.
And I'm a big person on representation when I'm in my office. So I point to a sink because every office and just about every room has a sink. I'm like, you like the pipes? You don't put bacon grease down them and not expect it to get clogged, right? And they're like, well, of course. I'm like, well, that's what we're trying to do. Is we're trying to remove that obstruction from the pipe, just like your arteries. And that tends to, or shouldn't say arteries, your veins, arteries, everything, tends to sell it to them pretty well. It gives them a mental, because like you said, they're not going to feel it. So I got to get them to understand it in some sort of way.
So how do you treat it, Tom?
Well, me personally, again, I think it's time to talk about levels again, because just like with the triglycerides, there's ranges. So for your total cholesterol, you want less than 200. The borderline is defined as 240 or below, high is above that, obviously. For the LDL specifically, because the total cholesterol is going to be the score of the HDL and LDL, really what you're wanting to look for is below 160 for your LDL. So realistically, again, it comes back to where are we at? If their LDL is normal and their total cholesterol is 240, I tend to go with, hey, if you don't want to be on medications, you got to start losing weight. You got to start exercising. You got to start removing fried and fatty foods from your diet, etc. If the patient, and I have actually had patients that are like, I know myself, I'm not gonna be able to do that. We're gonna need to go on medications, and I respect that. So I'm like, okay, here we go. So if they're either at a level where, based on their condition and other factors, they need to be treated, or they're just like, nope, just put me on medications, the go-to starting point is statins. And I say statin because there's a bunch of medications and they all end in statin.
Almost like it's a group of statins. I don't know.
Yeah. It's almost like the people that name medications plan this ahead. So, so with the stats again, there's a bunch of them. I'm sure everybody's got some of their go-to.
Lovastatin, simvastatin, pravastatin.
Let's say what.
Yeah.
Let's say, see, and my first usually starting point is a torvastatin, and there isn't any specific reason other than when I was going through training to become a nurse practitioner, that was the most commonly one used. So hence, that's the most common one for me to go forward. Now, I am not against evidence-based practice. If somebody says, hey, pravastatin is 10 times better in this, and this, guess what? I'm going to start prescribing pravastatin.
Right.
But the point realistically should be is not so much what specific one, it's just that you are getting them on one.
And some of that is also going to be dependent upon the ranges, like you said. If what they consider to be moderate intensity statin therapy would be like, say, lovastatin 40 to 80, or if you use a torvastatin, it would be like a 10 to 20 milligrams a day. High intensity statin therapy, you're going to bump it up a little bit, and like your torvastatin is going to go from 10 to 20, it's going to go to 40 to 80. The decisions made to treat with statins to achieve the 20 to 30% reduction in coronary heart disease events seen in most clinical trials. So you want to treat them with those dosages. It does say that they suggest starting treatment with a moderate dose of a statin, such as 20 milligrams of atorvastatin, but it is reasonable to start with high-intensity statin therapy for patients assessed to be at a particularly high risk, such as those with a 10-year risk or of 20% or higher.
One of the problems with statins and the training and in research, and I have not had this as much in practice, so that's why I want to talk to you about it, is statins have got a pretty bad rep for side effects.
Yes, they do.
Now, in reading about this, and again, I'm using websites like the American Academy of Family Physicians in particular for this one, statins have an excellent safety and side effect profile. The most common adverse effects from statin medications are GI disturbances, headaches, myalgias, and rash. By far, the largest percentage of side effects in personal experience with this are people reporting body aches.
Yeah.
That seems to be a very common one, even though the science shows again and again and again. As a matter of fact, there's 2 studies listed in both the AHA and the AAFP about simvastatin, pravastatin studies where the control group and the people taking it had the exact same amount. So there was they're like, the statins don't seem to be causing anything extra that people aren't already experiencing. But whether it's in their head or whether it's not, the general findings in all these studies are that the majority of patients within 1 year are going to quit taking medications from either true side effects or perceived side effects.
And one of the things, and I guess I didn't mention this, and I need to get better about this even with my own patients, and so I'm going to take responsibility for this as well. You know, we keep talking about like starting the statins and lowering the risk. Well, what risk are we talking about? So there's a website that you can use called cvriskcalculator.com, and we can throw that link down in the show notes. And it calculates your 10-year risk of heart disease or stroke using the algorithm that come out through the ACC and AHA. And so you plug in the patient's information as far as like their age, their gender, race, their cholesterol, blood pressures. If you're treating them for blood pressure, diabetes, and if they're a smoker, then you can calculate the risk of having a cardiac event over the next 10 years. And so that is what the American Family Physicians Group uses as far as the threshold for starting statin therapy, as far as for the lowering the LDL. And their recommendation is to initiate therapy if 1 or more risk factors and the 10-year risk is greater than 10%. And you need to consider therapy if 1 or more risk factors are met, and then the 10-year risk is less than 10%. So the majority of patients, if they're going to have any of those risk factors or are going to be at a higher risk for potential cardiac events, you're probably going to need to have that discussion about starting a statin to lower the LDL.
You know, one of the interesting things looking at that calculator, because I pulled it up real quick while you were talking, is it doesn't take into account LDL directly. It takes in the total and HDL cholesterol. So we've been talking this whole time, what's the biggest risk factor for an MI event? LDL. What's the one thing the calculator doesn't take into specific LDL. So I just thought that was really interesting just looking at it right there. I think I kind of skipped over it. So it's going to be important for a second just to kind of understand what the two different cholesterols are doing. Okay. So we know what we want from them in levels, but the HDL, the purpose of the HDL, and maybe why it's important to this calculator, is because what it does is it absorbs cholesterol and then takes it back to your liver, and your liver is then able to flush it out of your body. So that's why it's important to have normal levels of the HDL, because it's helping clean up, versus the LDL. What it's basically going to do is it's going to go and stick to the walls of your arteries, creating plaques, which is then what causes the strokes and the heart attacks. So I kind of skipped over that earlier. I'm sorry, Ben. Just thought maybe we should clear that up a little bit.
And when I mentioned risk factors earlier, current guidelines for treatment are any individual with atherosclerotic cardiovascular disease, individual with primary elevations of LDL greater than 190, any individual between the ages of 40 to 75 that their LDL is between 70 and 189 without cardiovascular disease. Those are the current recommendations as far as, again, initializing statin therapy. So honestly, Tom, I mean, I think I'm not great about statin therapy with my patients, and again, I'm going to take responsibility for that because I'm not. I mean, if you look at some of the risk factors and you look at the guidelines, I mean, the vast majority of patients, honestly, should probably be on a statin at some point. You know.
Yeah, and just as you said, I'm not great about statins. I'm just not, for a variety of reasons. One, because I like to try and keep my patients off medications as much as possible. Not that they don't need statins, and not that they don't need cholesterol therapy. That's not what I'm saying at all. But as I was just talking about, there's usually side effects, whether they're real or not. You know, if the patient believes they are, then they're there. Okay.
Yep,
So I have medications going into them that may be causing adverse effects that they don't want to take. If they're not going to take, it's not going to affect it. So especially with statins, if it's feasible, I try and focus on the prevention, the diet, the lifestyle, because hopefully I can make some headway there without putting them on a medication that then they are going to reject and not use anyways. So I too need to become much better at statin therapy, but I still hope that when I talk to my patients, I can make the point and impact on diet and lifestyle and exercise to help control it over the medications.
And I just want to touch briefly on and I don't know if you've had much experience with this. We've had drug reps come in and talk about it. The PCSK9 inhibitors, the pro-protein convertase subtilsalin,
I'm going to let you handle this part.
The PCSK9 inhibitor. We're just going to call it that.
Yeah, just leave it at that.
And that's going to be that, like, Repatha is the big one that you see that's out. And this is, I mean, it's got a really good profile, but it's also going to be one that not everybody is going to use for a variety of reasons. And I think probably the biggest reason that it's used is for the familial hypercholesterol. So basically those patients who are doing everything that they need to be doing, and the genetics are still bad, and they're so
they're just not making progress. Yeah.
Yes, thank you.
And I have said multiple times, diet, exercise, lose weight, blah, blah, blah. But that's, like you just said, that's not going to work for everybody. There is a genetic component for some types of hyperlipidemia. So in those cases, drugs like Repatha and do you know the other one off the top of your head?
I don't know the other one off the top of my head. Repatha is one that come to mind.
Praluent. Well, either way, no, I don't have. This is one of the topics I don't mind talking about and saying this exists. It's got a lot of evidence show that it is powerful drug for lowering LDL cholesterol. There just seem to be some incidental lowering of triglycerides, but that is not a recommendation for use of this medication. For a couple reasons, I'm not super familiar with it. So talking about prescribing it's not something I'm really willing to do because I don't have much experience with it myself. The biggest reason is most of my patients I'm dealing with, I have not had familial cholesterol being the problem. And the other is cost. It is a couple new medications, and cost is prohibitive for some of my patient pool.
Yeah.
While I have nothing against either of these drugs, I just have not found it to be a tool I've used many times in my practice.
And honestly, I mean, maybe I'm speaking out of turn. I don't know. But if we were to the point where we're looking at Repatha or something along those lines, cardiology is probably going to be involved. And the biggest takeaway from the Repatha and the medications like this, and the reason that I think it's going to be a very small subset of the population that would be either eligible to take them or willing to take them, is because it's an injectable. So that is, I have patients who I can't get them to take insulin with a blood sugar of 400, and I know it's going to make them feel better. And so then you have, and it's nothing on the reps by any means. I mean, and that's why I think this is going to be something more, we're going to have a cardiology consult involved, because again, I can't get them to take insulin injectable. I'm sure as hell not going to be able to talk them into taking an injectable medication that doesn't change the way they feel.
Yeah.
And that's why I think it's going to be someone who, like I said, is already plugged into cardiology, and someone who is already willing to cut their diet down to the extreme, doing everything they're supposed to be doing and still not getting there. Those are the patients that are probably going to be potential candidates for something like a PCSK9 inhibitor. Getting back to just statins and cholesterols and stuff in general, current recommendations, Tom, are that the cholesterol should be measured 6 to 8 weeks after initializing a statin therapy, and once the appropriate level of reduction has been obtained, then the test can be repeated every 12 months thereafter, or if the clinical situation dictates.
That is a really good point to bring up, and far too often, especially in the beginning, and I am probably as guilty as anybody I am talking to at this point in time, but we have got to make sure when you provide a medication for treatment that you probably need to follow up and make sure it's actually doing what it's supposed to be doing, especially with patients with multiple medications. I know it's easy to, hey, I'm going to start you on something, and sometimes, especially a statin medication, can get lost in the sauce, and maybe appropriate testing isn't being followed up on. So that does happen, but it is important, like Ben said, every 6 to 8 weeks in the beginning while you're titrating the drug, and then 12 months when you get to a therapeutic level. But I think that's one of those questions or things people, especially in the beginning, they're so wrapped up in trying to figure out what medication to put them on that they may not always know the appropriate time frame or even to follow up immediately on it. So that's a good one for the new practitioners out there.
Well, and the other reason that I bring that up is because I wanted to segue into this comment from the American Family Physician in their what they call POEMS, which is patient-oriented evidence that matters, in the June 2019 issue, which is the overview of the new ACC/AHA lipid guidelines. The clinical question that was posed was, what do cardiologists recommend for the management of hyperlipidemia? And here's the bottom line, according to the American Family Physician Group. These updated guidelines are made without any input from primary care physicians who manage most patients with hyperlipidemia, and are more complex than the 2013 guidelines, and will likely lead to even more recommendations for statins, Zetia, and PCSK9 inhibitors rather than a fire and forget strategy involving a risk-based prescription for moderate to high-level statin. We are supposed to go back to the monitoring LDL levels and targeting a percentage reduction in LDL cholesterol, and in very high-risk patients targeting an LDL level of less than 70 milligrams per deciliter. Is their bottom line of, so that, and we're seeing that with some of the guidelines now of, don't just put them on a statin and leave them there, but you're going back to kind of reassess that. And I talked to you a little bit about this before we hit the record button. It almost kind of sounded like a little shot from the AAFP there to cardiology, well, in my humble opinion.
No, I'm pretty sure the guy who wrote that was like cussing under his breath while he was typing it. Like, them sons of bitches, I'll tell them what they're going to do. Like, I could just imagine some mad guy in the middle of the night typing. It's just kind of funny to me. But I don't just think it's funny, because it is amusing to think about. And I think it's important, though. I think they're right. I would assume that family practice is handling the majority of identification of hyperlipidemia and treatment options. And cardiology coming in and dictating what's going to happen is inevitably going to paint them into a corner where we then have to refer them to them for treatment. And I think that's a lose-lose situation for both the healthcare systems and the patients.
And in case you were curious of whether that was a shot at cardiology, you scrolling down through, quote, "It is also worth noting which organizations were not among the 12 that endorsed this guideline: the American Academy of Family Physicians and the American College of Physicians. This is reminiscent of the recent aggressive hypertension guidelines from the ACC-AHA that the AAFP and ACP also did not participate in or endorse." Maybe a slight shot at, not necessarily cardiology, but maybe more at the AHA and ACC.
And for those out there wondering, I'm not mad at any cardiologist, but I think this is more of the large scale macro political things that can happen within even the healthcare systems, and cardiology doesn't want to appear to give up some of their ground. Maybe, I don't know, that's some speculation on my side.
I don't even know if it's that or if it's, like you said, family practice is going to be where the vast majority of these cases are going to be handled. We're going to be kind of be the infantry, so to speak, of the daily use, and your cardiology are going to be your Green Berets, and you're not kicking everything out to the Green Berets. But yet the Green Berets are the ones who are writing the policy that affects the infantry, and infantry is like, but we didn't get a vote. And it's like,
exactly. Yeah, we are going to be expected to handle something that we didn't help craft. And with anything else in life, that generally ends up poorly eventually.
You know what it just reminded me of? And again, no offense to anybody at the AHA, ACC, anywhere else. It's kind of like politicians, Tom. Like you've talked about, there are politicians who are writing policies that don't work in the day-to-day process of that.
Yes, I have big problems when politicians start talking about science or enacting new laws involving healthcare, but they don't actually have any science background or experience with healthcare. It never is going to go very well at all. I thought you were going to say another example of this is how poorly the Cowboys seem to be doing in this draft.
I think we did quite well, thank you. Just so far, round one, I think our linebacker core has been decimated, and we've.
Oh, that's not a joke. I just did the little Catholic cross my chest when talking about his linebacking core.
Micah Parsons is going to be, a new Dallas Cowboy middle linebacker. It'll be good. But Tom, getting away from Cowboys football, and it's really hard for me to do that. But if there are other topics out there as far as back to basics that you want us to cover, let us know. We've hit hypertension, we've hit hyperlipidemia. Obviously, we're not going to be able to give you everything that you need in an hour, but hopefully there's some good jumping off points to where you can go to find information or at least start to treat your patients and go from there. So if there's other topics that you want us to cover that you see a lot in the office, let us know. Facebook, Instagram, Twitter, YouTube, all at Just Some Podcast, website, www. Ooh, words are hard, and so is our website, apparently. www.justsomepodcast.com. Email us, admin@justsomepodcast.com. So, Tom, we got the another back to basics out of the way, so that was good. We got our next topic for our medical mysteries episode coming up as well. So it's going to be some good stuff on the way.
It is. I am, as always, excited to get these episodes out and see how people react. And I am really excited about our medical mysteries that we're starting to pick up and do. And if it keeps doing this well, hopefully it becomes a more regular part of the show.
Yeah, I think it would be great. And with the draft, maybe we can reach out to our sports medicine guy and see if we can get him on the show. And I know that John Canyon, he was on and talked about RVUs and stuff. He reached out and wants to come back on. Multitude of potential guests coming up as well. So always some good stuff coming up on the old JSP. But we're going to let you guys get out of here because you got to go to work. Tiffany. You got to go to work. We know that. Wear your mask. Wash your damn hands. Have a great week.
Hey, everybody. Make sure you stay safe out there.
Cowboy, you're rocking.
Practice swearing just to pass the time. Lately Slowly I see why I am alone. I caught some road rage and I thought of you, and all the many times you say I should have known. Took a class so I could find my G, find mediocrity's the best that I could do. Meant to shower but I slept all day. It takes everything to live the life I choose. Oh, what do you say? I screw up everything again. Oh, what did you prove except there's only more for me to lose? Failure's not the same without you.